Hello and welcome. I'm Barkha Dutt. You're watching the Mojo Story, our digital platform that continues to make the COVID-19 pandemic and its second wave priority for our journalism and our reportage. Today, we're looking at the controversy surrounding the gap between two doses of the COVID vaccine. This is a debate that has been ongoing for a long time, but it hit the headlines again after this report by Reuters. Reuters reported that at least 3 members of the COVID working group went not really on record, but off record, told the media that they were not particularly comfortable with this 16-week gap between the two doses. And members of the working group then went on to say that they had not specifically made this recommendation at all. Remember, the government had said that it had gone by the advice of its experts. What is the exact position on what the working group said and didn't say, agreed to and didn't agree to? And of course, looking at the larger questions around not just the Delta variant, but now what's being called the Delta Plus, and also the reports of an imminent third wave. We're joined by JP Muliyil, Dr. JP Muliyil. Let's bring him into the screen now, one of our foremost leading experts, and also, as I said, a member of that COVID working group that has been in the headlines. Welcome to the program, sir. Let me start by asking you to settle once and for all the media reports on this controversy. Reuters reported that 3 members of this working group, of which you are a member, and it also named you as one of the members, were not very comfortable with this 16-week gap, this increased gap between the two doses. It further said that 3 of you basically made it clear that you had not made any such advice to the government. Where do you stand on the Reuters report, and where do you stand on the principle of the 16-week gap between the two vaccine doses?
My mother tongue, and many of the reporters who speak to me did not, don't speak. I mean, that's not mother tongue. But this is a little difficult version to come to communicate with you. I was one of the people who always said there should be one dose itself is quite good because the vaccine is excellent. I may be wrong in that, but I continue to see evidence that one is good. So delaying that by that much time would not have hurt me at all. And so this particular news, this particular gentleman who spoke to me, I remember telling him very clearly, there was consensus of opinion regarding delaying the second dose. The actual time interval was not worked out completely because it had to go to the group which does the organization, delivery, and they need to be comfortable with too. But we had okayed it. And I thought this was over and past. We have looked at it. I have agreed to forgive him. And shall we stop with that?
I just want to understand, you're saying that the report was a consequence of being lost in translation?
I have a feeling because I only speak what I feel in my heart. I don't change my opinion. In fact, if you look at my whole history of talking to the media, I've consistently said certain things, even in the face of obvious errors, but I said the reasons why it happened. And there is nothing lost pride here. The question was, do we have adequate amount of vaccine? No. Which is a better idea to approach the whole problem with? 1 dose at least to most, or finish the 2 dose and then look around. I mean, it didn't make much sense to do that. So there was a gap, tactically a good move. And I think all my colleagues agreed on it. And the circumstances under which these interviews occurred was less than desirable. So I think we won't dwell on it. We have more important things to talk about.
Okay, let's put the Reuters report to one side, but there are still questions about what we should do in the light of a new UK study, relatively new, that seems to say that you need 2 doses of any vaccine, whether it's the AstraZeneca or what we call Covishield, or whether it's the mRNA vaccine, because one dose provides you 33% efficacy against infection. I should make it clear that this is against infection, not hospitalization. Whereas one dose provides 71% efficacy against hospitalization, which I understand is what we are concerned with in India. Now, it was this research, as you know, Dr. Muliyil, that led the United Kingdom to relook its own recommendation of what the gap should be between the two vaccines. So I'm not as much concerned with the controversy around the Reuters report as I'm concerned as an Indian and a journalist, simply saying that if we need both doses to actually have the required efficacy, then we need our government to say that the reason that the increased gap is there between the two vaccines is a result of the shortage, not as a result of the science.
You got a point there. Remember, this particular vaccine was originally designed as a single dose vaccine, just like Johnson and Johnson. Halfway through, they decided to make it a two-dose. And in fact, we have not seen any substantial reason why it is so. Now, remember, with this particular way of calculating the protective effect, there are several methodological issues. Data emerging from randomized trials are for one quality. Data coming from observational studies are a different quality. We also have, there are other studies which show a very high protection from single dose vaccine. Now, we never said that there should not be two doses. All we said was there could be a delay, and that is justified, especially in the context of a vaccine deficiency in the country. So these things have to be weighed, and I say and risk versus benefit. And I think that decision was based on the fact that it is not unsafe to let people on with one dose temporarily and add it up with the second dose.
What we've seen in the second wave seems to suggest to us that the Delta variant that we're dealing with was, of course, much more lethal. And therefore, even AstraZeneca/Covishield's own finding, which it discovered by accident in its trials that an increased gap actually made the vaccine more protective, did not apply to this particular mutant strain. What do we know about the efficacy of a single dose against this particular Delta variant?
Two things I would suggest to you offhand. I mean, I'm not giving you a reply and a court of law. I'm just talking to a friend of mine. One is a study from Christian Medical College, Bello, showing excellent protection with this vaccine. And you know what was plaguing us around here? That mainly Delta variant. Number two, the study from Public Health England describing the fatality of all the various variants shows that Delta variant has one of the lowest case fatality rate, 0.1%. Now, why is that? Because there was a good coverage of these two vaccines, AstraZeneca and one other mRNA vaccine. So it looks like that particular conclusion that is more lethal is not quite correct. And I think this is, when you see studies here and there, and sometimes it's a little confusing, but check the case fatality rate. It's much lower in England with Delta variant than for the earlier variants.
Could that in fact be because more people, more than 50% of England is already vaccinated, Dr. Muliyil? That's the first question. The second question is that the CMC Vellore survey was done primarily, please correct me if I'm wrong, on health workers. And therefore, is it representative of a larger sample? And I'll throw in a third question. If indeed you think the Delta variant is not more lethal, because all studies seem to suggest that it is more than, it is 50% or 60% more transmissible, then why have we seen the kind of spurt of fatalities that we saw in the second wave in India?
I have looked at the mortality rate, whatever available. And in Indian context, mortality is very, very underreported. So it's difficult to look by it. But what I was quoting is that in the context of UK, with a good coverage of vaccine, this Delta variant has shown not to be outwardly lethal. Now, that means at least the vaccine protects. Now, where is the evidence actually that there is a higher case fatality rate from India? We don't have now. There's nothing we have to say. There are more cases. Exactly. This is more infectious. How many times? Maybe 4 times more cases. Yeah, so deaths also will go up. But it has not reached the level to state confidently. Even UK tried calculating this for us. There is no clear evidence that mortality is higher than the earlier variant.
I'm really surprised to hear you say that, because you're actually saying that what we know about the Delta variant is that it is more infectious, but not necessarily more lethal. Am I actually understanding you correctly there?
Yes. Now, there is a reason why I tell you this. Early in the game, that is last April, I actually calculated how many people would die in India if India were to experience the same mortality rate that they were experiencing in UK, France, and Italy. Same age-specific mortality. And in my calculation, it is an underestimate. It was 2.2 million deaths, COVID deaths alone. So I speak in the context of that background information. So I am not completely comfortable in using that data because Indian data on mortality is an underestimate. Despite that, the expectation, now how did I calculate the expectation? Based on the mortality pattern observed in UK, France, and Italy.
Yeah.
So, and that is 2.2 million.
That is what you anticipated. Just to be clear, that's not what you think has happened. So we need to actually fix that banner. Yeah, but go ahead. Yeah.
Now, but the same variant came to India, and we were seeing extremely low death rate. And I was very anxious. Our death reporting is not good. Same way, impressions on mortality based on photographs, bodies is not correct. You have to go through it. Luckily, we have some very keen scientists who are working on this, trying to estimate excess mortality, and I'm sure there is a lot of underreporting. But I am trying to answer your question. Where is the evidence the Delta variant per se, given 1,000 people are infected by that, the death rate is higher? I have not seen it.
So you're saying that the number of absolute cases is higher and therefore the absolute number of deaths in a short period is higher. But as a percentage, what's called the case fatality ratio, you do not yet have conclusive evidence that the Delta variant is more lethal than the Alpha variant, right? Okay.
Yes.
Let me ask you, therefore, are you comfortable with the 16-week gap? I understand that there's a practical issue of a vaccine shortage, but I think that the problem is that the people of the country have not been told that this gap has been set because of a shortage. They've been told that this gap has been set because the experts say that this is a good or acceptable gap. Is this an acceptable gap? Or in between these gaps, are we as citizens much more in danger of being hospitalized on just a single dose? Or is the answer that we do not know?
I think there are several reasons why people make decisions. And if this particular point that there is a deficiency of vaccine in India was not adequately emphasized, that is probably not correct information. It had to be taken. That's a reality, and everybody knew that. Many places, vaccination programs had to be arrested because there was not enough vaccine. And that is nothing to shy away from. It is a fact. Did we do smartly? No. We kind of messed it up a bit. However, that is definitely meant, in my mind, the decision-making process was pushed by that one notion.
Okay, that's candid enough, and I think it gives us a context to move on to other issues. Now, we are at a stage where there is talk about an imminent third wave. Having traveled across India, particularly to rural India, I'm not fully convinced that we know the scale of even the infections and even the deaths in rural India, where many people I've met have, the relatives have told me that people died at their home. They did not even reach a hospital. They did not even reach a doctor, and therefore they were not counted among the dead. Secondly, there are many families we met who did not have access to an RT-PCR test. Do you believe, Dr. Muliyil, that the second wave is in fact over, or do you believe that it is too soon to declare it over?
Second wave is coming down just the way the first wave came down. And the problem with the first wave is when it started coming down, the national average seropositivity was 25%. And I remember a friend of yours who was anchoring a program asked me this question: are things getting better? Shall we say this is the way is the end game? And I was reluctant because that 25% was not adequate in my book. It had to be more than 50%. And I said, I need some more weeks to decide which way it is going. But that particular fall was tantalizingly, tempting to say, yes, I think we escaped. But came a new variant, more infectious, and another one that is even more infectious. So together we had this double variant, which has got pretty high infectivity. Naturally, the herd level that you expect goes up. Currently, it is expected to be 86%. Now, 86% is mainly in urban area. In rural areas, it may be up to 60%. So given this kind of a scenario, the question is, was this last burst large enough to push the overall seropositivity to around 70+%? If it is so, we can be rest assured at least there won't be a big wave. You need susceptible to create a big wave. That's why pardon. So go on.
I have a question, because let's even assume that 70% of India or Indians are seropositive, and therefore we may escape a very bad third wave. Does that factor in mutations? Because that's what we thought at the end of the first wave, and came this new variant called Delta. Now we're talking about a Delta Plus. We're already therefore seeing a mutation of a mutation. Now, if that happens, just in layperson's terms, I want to understand, does the seropositivity give us protection?
So far, every variant has honored the seropositivity acquired from a previous infection. And that was a saving grace.
For how long, Dr. Muliyil? For how long?
Now, there is one more line I have to add. From the beginning, we were taught by the knowledgeable people there will be no seropositivity. Then they said, no, even if it came in, it will be short-lived. First of all, they said maybe 1 week, 1 month, 3 months. Now we know it's a long-lasting immunity. Just like you get in measles, chicken pox, there are some diseases who induce long-lasting immunity. And at present, corona looks like one of them. Now, am I going to fight against that notion? No, I'll be scared of it, but very good studies have shown this is a good vaccine. And so far, for the whole period, we have not had any large-scale reinfection. That is previously diseased people falling sick again.
I mean, we've had some cases, but most of them have been doctors or health
Yeah,
workers,
that's correct.
from
But
what
the
I can tell.
numbers we are expecting when a new strain comes are as they will ignore the previous immunity and they will just start infecting everybody else. Then, Barkha, we have got no choice but to go through the whole process again. We'll be meeting again and again over these interviews.
Yeah, but where are we in your estimation?
I
We
don't
don't
think
actually know. We don't know if we're at 70% seropositivity, right? We don't know.
so. We have ordered that there should be a nationwide sero survey. Okay, and also many state governments are now coming up with the sero survey plans. So, and the time is ideal when the wave starts coming down to a low level, and that's when you get the maximum amount of information. And see, we have to have a positive attitude towards the whole thing. You keep on hearing of Delta plus plus plus, and then we will have as a country, we'll go down. So let us hope that things will work out. How long will we keep our children away? There is a belief that children in the first wave were not infected. Children in the second wave were not infected. That is false. We have zero survey to show children are as much infected as adults, but they are smarter than adults. They know how to get out of the problem. They overcome COVID very graciously, which we can't do.
Yeah. In fact, there are pediatricians who've argued that the third wave could hit children in specific. Are you convinced about the science of that?
I'm not convinced about the science of it, okay? But in this, under the sky, anything can happen. But this is very difficult for me to digest because children's rate of infection is exactly same as that the elderly. And who wants children to get into trouble? But that doesn't mean don't get ready, don't plan enough beds, don't. That I'm not saying. I said we hope this will not happen.
Tell me this. You said that the working group has advised a nationwide sero survey. Do we have enough time to wait for the results of that to know if 70% Indians have already got COVID, many of them without knowing so, asymptomatically, before the third wave hits?
We can do it very quickly, and it is not the working group who suggested it. We have another committee who looks at these kind of strategies. I am a member of that. In that committee, it was suggested, but more importantly, now each state is taking a lead in making sure they have district-wise information on how positive are in the urban, rural area. And so, without information, guessing is not good. And we will not take very long to finish a survey the moment the word go is given.
There have been timelines that have been put on the hitting of a third wave. People have suggested that it could come as Maharashtra thinks it could come as soon as the next 2 weeks. And Maharashtra has in the last 2 waves always been the first state to be hit. Nationally, there's a suggestion that we could be 6 to 8 weeks away from it. There is absolutely no way at the current rate of vaccination that we can vaccinate a significant part of the country before that, if this timeline is correct. Do you agree with this timeline? And then what do we do? Because that means that vaccines are not our answer at the moment.
Yes. So far, most of our fight, our own immunity has done. And fortunately, that immunity seems to be doing well. So don't forget that part of it. We are not hopelessly situated. Now, it to happen, there should be a new variant, which is even more infectious. Now, already 86% is our, level of herd level required. So there is not much space to move around. This guy is doing all the harm it can. That is this double variant or Delta, whatever it is. So don't wish for anything more disastrous. Okay.
No, why would I? I would not. I would hope that the virus mutates into a weakened version of itself, but the fact is we don't know.
Yes, I agree with you. We'll call it mu virus, which causes a lot of infection and no disease at all. So everybody is immunized with that.
But we don't know enough, right, Dr. Muliyil? We don't know. And one thing that worries me is that the number of large congregations that we've seen, the mass gatherings, whether during elections or religious festivals, please correct me if I'm wrong, but the larger the number of infections, and we've seen a huge volume of infections, the more the chances of a mutation. That mutation can go either way. It can weaken the original virus, or it can, make it more lethal. So we're a little bit groping in the dark here, aren't we?
Yes, but that why is this coming down? Everywhere is coming down. Why did it come down in Delhi? Because home for the virus is missing. That is, susceptible population has gone down. So if you allow the trend to go, and down it goes, we need to do one little favor to our country, each one of us. Wear a mask whenever you are in crowd, especially when you are inside a building. Otherwise, that is a little contribution we can all make to the defense of our nation. And so I think if you can, at this point in time, not leave all caution to air and then say, corona is gone, let us have fun. We are not there yet. We have to wait for the vaccination program, and these vaccination programs has to cover a very large number of people. This is why it is important to remember that those who are already infected are immune. They're equal to vaccinated people. So we don't have much of a worry. We just push the vaccine and get especially the vulnerable group in, and then we should be able to face everything.
I have two questions about both the vaccines, the Covishield and the Covaxin, that we currently mostly administer in India. We'll have more vaccines soon. I know we have the Sputnik already, and I know more are on their way. But of the two, let's start with Covaxin. There's been a huge amount of debate over the absence of the phase 3 trial data, because of which the World Health Organization has not yet approved this vaccine. How much does that concern you as a scientist? And I'm not saying the vaccine isn't safe, and I just want to underline again and again that for our audience, this by no means sort of amounts to your wondering whether you should get the vaccine or not. If you have a chance, please get it. This is just a deeper research question that I'm asking Dr. Muliyil. Are you concerned that the Covaxin data is still not available in public domain?
Well, I'm concerned. I have no clue why it is taking such a long time. And there is no valid explanations why it is not out there. And it is, I don't know. I don't know how to answer you on that. And we went in trust that it will work out. But the only evidence I know is some lab studies which showed that most variants respond to this vaccine-induced immunity. So that is, there's a lab evidence, and given that lab evidence, they should be able to give us the final data. And I can't just imagine why this is such a situation.
So does it worry you? Does it annoy you?
Absolutely.
What's the word you use?
Absolutely. And we have, and as a group, I would like to say we will give a deadline, should give a deadline, and say after this, forget it. We have to. In fact, we have been looking at other vaccines too, and screening them and one by one. And Barkha, the problem is the science behind the vaccine is very simple. Introduce the antigen to the body, and body will do the rest of the work. Okay? Vaccine is not creating our immunity. It's a body that creates. So in that principle, the Covaxin should work. Okay?
Yeah.
Work well.
Yeah, you said as the group is thinking of setting a deadline. What would be a reasonable deadline? And do you think we're
No,
already
no,
past that reasonable deadline?
no. I said we should put a deadline.
Okay, you feel you should. What would be a reasonable deadline in your estimation?
I mean, this particular wave is over almost. There's no waiting for any more cases to accrue. That is not possible. So, if at the end of this particular, in a month's time, they don't produce the data and they don't produce the evidence, then I think we should say, okay, we gave you a chance. This is a hell of a long time that is going on. But I may be saying this because of my ignorance, because there may be something that I am missing out on all these things. Why is it going on so long?
Yeah, it's bewildering. As you said, I think people will then start. The problem with this also is that it fuels vaccine hesitancy at a time when we can ill afford it. My other question was going to be about the other vaccine, Covishield. Now, you've seen sections of the world believe that the Covishield, what they call AstraZeneca, is not desirable for certain age groups because of the clotting controversy. I know that the numbers are very minuscule, but parts of Europe and even the United Kingdom have chosen, for example, to give younger people mRNA vaccines. Are you concerned about the clotting controversy and Covishield?
I think the reason why I am not that worried about it, and definitely there is a problem, I am not denying it. Indians on a whole manifest this problem at a much lower rate than Western population. That is a very well-known phenomenon. And people think it is because of their diet or whatever it is, but we have this particular disease in general, we have it a lower frequency. But looking at the pathophysiology of why it happened, we should also be seeing more. At least the explanation for this whole clotting phenomenon is a bit more complicated. And that suggests that we also should see. We are not seeing it. So we probably should increase our vigilance on such phenomenon, because this is a problem, how much of a surveillance we do on post-vaccine complication. At least in selected areas, we should sharpen our focus and make sure.
Yeah,
Yes?
sorry. Just to clarify, you're saying that we are not seeing clotting in India in the way that other parts of the world have, and we don't know what the science or the reason for this is, but we need to keep an eye. But at the moment, if I'm not wrong, 90% of those vaccinated in India continue to be from the Covishield. It continues to be the single most used vaccine globally as well. Europe is having a rethink, though, on the AstraZeneca. You're saying we don't need to worry about it at all right now. We just need to keep an eye on post-vaccine complications.
Yes. The reason is the incidence of the disease is very rare, even in Europe. And our predisposition to this clotting is a little lower. But that doesn't give us reason to, sit, relax and say, don't worry. I suggest that at least in selected centers, selected population, we follow patients for evidence of any complication with this. Not nationwide, we are not capable of it.
Okay, I want to take you back to your point about excess death data and trying to get some sense of how many Indians have actually died from COVID in both waves cumulatively. Now, so I've spent some time tracking the uncounted across multiple states, and different mathematical models have emerged. There are those who suggest that the factor could be anywhere between 5 and 8. There are others who say the actual deaths could be 10 times higher. You anticipated 2.2 million COVID deaths. Our official numbers are, don't even acknowledge anything close to half of that number. If you had to do your own math, do you have any sense? Would you put a number on how many people you think may have died, given the models you've seen so far and the images we have seen of the mass graves, abandoned bodies, especially in the north of India?
Yeah. There are most bodies that we lose are never seen. Okay, an elderly lady suspected to have COVID need to get admitted in a hospital, say government hospital, without any attendant. Would she rather say, I would stay at home? I am not going to any hospital? Yes, she would choose not to, because in Indian system of healthcare, an attendant is important. And this COVID disease, we have decided to tackle by admitting people without an attendant. And the highest risk group is elderly. And those who is going to agree to that kind of elderly people, 80s and 90s? So I don't think we have seen quite a few of them are missing from our list. In fact, if you follow the expectation, 90% of the deaths should be in the age group 60 plus. We don't see it in India. We only see 80%.
Mhm.
Second thing is, look at the data from Bihar and
Yeah.
Kerala. The case fatality for these two states are almost identical. Okay,
Mhm.
0.4%. Now that is
Mhm.
incredible. So, you know, the variation we are dealing with is huge. Usually, when you have good information, you can make a good assessment and good projection. But this, the data that we have, is so hopeless. So we have to now go to areas where the reliable data is available, eke them out, and those efforts are going on. Okay, so forget about nationwide data analysis. That's not going to work out. We have
Mhm.
to get good information from smaller areas.
What does your modeling tell you? You had an
No,
anticipated number. Do you have enough data to even, are there any projections you believe more than others? Any studies you've looked at that seem more convincing to you than others?
no, not me. I don't do any modeling at all. Okay, I depend on my students who are good
Yeah.
at it, and they remember this particular 2.2 million was calculated based on an expected herd immunity level of just above 55%. Now I told you it's gone up, so that means the infection rate increases tremendously. So the expectation based on European data is much higher. Now
Yeah.
I cannot see why we should have any lower mortality. You understand? Okay. Why should it be less than UK?
Yeah.
Or
But that's what we
so
believed in the first wave. We believed in Indian exceptionalism. We believed that we were hardier people. We believed that fewer of us were dying as a percentage of population, right? And we got a rude wake up call in the second wave.
yep.
Yeah. So when you say we're not less prone to mortality, you're saying everything would depend on the levels of herd immunity. And we need to have that number to have an accurate sense actually of our case fatality ratio in the second wave.
Yes. That is correct. And I think that allows us to predict future waves. It
Yeah.
also allows us to look at the proportion dying, how much is expected, how much is. Now, it is interestingly, people are now, many state governments are offering money for families who are dead. And now the request for death certificates are increasing.
Yeah.
So we'll see how it works out.
Yeah, and of course, I can tell you that in many death certificates, especially in smaller towns, doctors are just writing pneumonia instead of writing COVID. So there's all of that needs to be reconciled. I have time for a last question, Dr. Muliyil, and that question is this: I know you to not have been a fan of lockdowns for good reasons. This time, the states took the approach of localized lockdowns. If there is a third wave, and we've already agreed that we don't have enough vaccines to contain the third wave, so either we all wear masks and we follow COVID appropriate behavior. That's one way of fending it off. And the other way is to desperately hope that enough Indians have already been infected, but we don't have the number on that yet. Do you think we're heading for another spell of lockdowns, or is the answer quite honestly that we don't know?
See, there is an old saying, if the hammer is the only instrument you have, everything in the world will begin to look like a nail. At the moment, the governments have only one equipment, lockdown. So whatever happened, they'll respond by saying, let's lock down. I think it is a secret is that they find it convenient to control crowds, create law and order in the face of this calamity. We should actually strengthen people to respond to these things, be on their own. See, we cannot win the battle without the support of people, and in interacting with them, encouraging them, making sure they understand, they cooperate. It has to be a people's movement. It cannot be a government alone movement.
Yeah.
So I
Yeah.
think, yep.
Yeah, well, I think that's well said. But unfortunately, what we've seen in the last couple of days of cities unlocking is that people have been so hungry to get out that we've just seen a surge of people. And I think we have to hope at this point that we have. What a strange thing to say, but I was just going to say that we have to hope at this point that enough Indians have already been infected. I never thought I would say that sentence in my life, but we do live in peculiar times. Dr. Muliyil, always such a pleasure. Learn so much from you. Thank you. Thank you for talking to us.
You're
And
most
see you
welcome.
soon again. I hope with better news the next time we talk. Thanks for talking to us. And to our audience, thanks for watching. See you soon. It's great to see you here. Thank you for watching our work. If you haven't subscribed yet, don't forget to click the bell icon and subscribe to Mojo Story and support independent, robust journalism.